Bismillahirrahmanirrahim. Today in our online lecture, we will discuss the malignant tumors of the bone. In our previous lecture, we discussed the benign tumors and we also discussed how to classify bone tumors. We know that a tumor is the result of excessive and uncontrolled cell division of the bone. There is uncontrolled cell division in the bone, and this excessive uncontrolled cell division result in the formation of a mass known as the tumor. We know that cell division is a very strictly regulated process. By that we mean that two groups of genes are specifically involved to control cell division. One group is the proto-oncogenes, and the proto-oncogenes allow cell division when cell division is needed. When there is no need of extra cells, these proto-oncogenes do not stimulate cell division. But if these proto-oncogenes get mutated, they are then called as the oncogenes. And due to the mutated proto-oncogenes or oncogenes, the cells undergo uncontrolled cellular divisions. The second group of genes involved in the formation of the tumor are the tumor suppressor genes. Normally, when a cell have a mutated or damaged DNA, the tumor suppressor genes do not allow these cells to divide and either send them to the DNA repairing workshop, or if the damage is so severe and cannot be repaired, they cause the apoptic cell death of the mutated cells. Similarly, like the proto-oncogenes and oncogenes, if the tumor suppressor genes get mutated, so this will allow the mutated cells to divide uncontrollably and will result in the formation of a tumor. The bone tumors that result from the uncontrolled bone cell division are divided into benign tumors and malignant tumors. The benign tumors, comparatively, they are innocent, they are confined and restricted. They do not cause local invasion as well as they do not metastasize to the remote organs. On the other hand, the malignant tumors are very aggressive. They are locally invasive and invade the surrounding local tissues as well as through blood, lymphatics, and other ways they can get metastasized to the other organs of the body, to the remote organs, and where they can give rise to malignant tumors. The malignant tumors of the bone are divided into the primary malignant tumors that primarily arise from the bone cells. We know that the bone cells are the osteoblasts, osteoclasts, and the bone marrow contains some primitive cells known as the neuroectodermal cells and primitive mesenchymal cells, and tumors arising from these cells form the primary malignant bone tumors. The secondary malignant bone tumors include those tumors where the primary focus of the tumor is somewhere else in another organ, but the tumor get metastasized to the bone and the organs from where the tumor cells metastasize, forming tumors in the bones, commonly include the breast, thyroid gland, the lungs, the prostate gland, and the kidneys. So these are the common sites from where the tumors metastasize to the bone. Here it is important to say that secondary or metastasized bone tumors are more common than primary bone tumors. The three common malignant bone tumors include the osteosarcoma, which is a tumor that arises from the pleomorphic osteoblasts. We know that the osteoblasts are the bone forming cells, and by pleomorphic osteoblasts we mean osteoblasts of variable and different sizes. So osteosarcoma is a malignant mesenchymal tumor. It is formed and it contains contents of the mesenchymal origin. And this malignant mesenchymal tumor arises from the pleomorphic osteoblasts. The second most common tumor is the chondrosarcoma. And by chondro we means that this tumor will form cartilage. And this is the second most common malignant mesenchymal tumor which will form the cartilage. The third malignant tumor is known as the Ewing sarcoma. And as we know that this tumor arises from the neuroectodermal cells in the medullary cavity and bone marrow, and this Ewing sarcoma is a very aggressive tumor which contains small blue round cells, and this tumor commonly affects the young age groups. The Ewing sarcoma is the result of the translocation, which is a type of chromosomal disorder in which the genetic components of the two chromosomes, for example 11 and 22 chromosomes, they are exchanged. The osteosarcoma, as I said, it arises from the pleomorphic osteoblasts. We know osteoblasts are the bone forming cells, and they lay down the osteoid, which later on become mineralized to form the mineralized bone. And these osteoblasts, particularly the pleomorphic osteoblasts, by that we mean that the osteoblasts of different sizes. So osteosarcoma arises from the pleomorphic osteoblast, and as a result it will produce excess osteoid bone. The common sites of the osteosarcoma are the metaphysis of the long bones. And as we know that in young individuals, the growth plates, they are located in the metaphysis, and in the growth plates and in the metaphysis, these are areas of rapid and excessive cell division. So the osteosarcoma commonly arises in the metaphysis of the long bones in younger individuals. It may also occur in old age, but in that situation, usually osteosarcoma is associated with some other precancerous conditions. The two very important mutations that are associated with the osteosarcoma are the mutations in the PRB and P53 genes and PRB and P53 proteins. And it is important to note that the mutations in the PRB genes and proteins is also associated with the familial retinoblastoma, which is a childhood malignant tumor of the eye. So in this situation, the osteosarcoma share genetic mutation with the familial retinoblastoma. The second gene, P53 gene and P53 protein, is also seen in the Li-Fraumeni syndrome. And in this syndrome, a variety of cancers occur throughout the body, along with the osteosarcoma. So, osteosarcoma share the P53 gene and P53 protein mutations with the Li-Fraumeni syndrome. So, the osteosarcoma is the bone-forming malignant mesenchymal tumors. Some bone tumors form cartilage and some bone tumors form the bone. So it is a bone-forming tumor which is a mesenchymal malignant tumor. And the common site is the metastasis of the long bones, particularly around the knee, like the lower end of the femur and the upper end of the tibia at the level of the metaphysis. Now, this tumor may produce either mineralized or unmineralized osteoid bone. Because the tumor arises from the pleomorphic osteoblasts. So osteoblasts, even normally they lay down the osteoid, which is the unmineralized bone. And later on, this osteoid become mineralized after the deposition of hydroxyapatite, calcium and phosphate. So in osteosarcoma, we may see mineralized as well as unmineralized osteoid bone. Osteosarcoma is a very aggressive tumor, and most of the time it gets metastasized to the lungs, where it will give rise to problems associated with breathing, and most of the patients sometimes die of the pulmonary problems. Three-fourths of the osteosarcomas, by that we mean 75%, they occur at young age. And this is the young age where there is excessive cellular division, proliferation at the growth plate, at the metaphysis of the long bones. So 75% tumors occur in the young age, and the rest 25% and 1/4 of the osteosarcomas occur in old age. But it is important to note that in old age, the osteosarcoma is mostly associated with some precancerous conditions like the Paget disease, bone infarcts, and radiations. Now, the osteosarcoma may be osteoblastic sarcoma if it contains lot of osteoid tissue and osteoblasts. If it contains lot of cartilage, we say this is chondroblastic sarcoma. And if it contains lot of fibrous tissue, then we say this is the fibroblastic sarcoma. So it depends on the content, mesenchymal contents in the tumor, which gives the tumor the name is osteoblastic sarcoma, chondroblastic sarcoma, or fibroblastic sarcoma. Radiologically, the osteosarcoma gives the appearance of the sunburst. And here we can see that the tumor is streaked out like the sun rays. And this sunburst radiological appearance is very specific for the osteosarcoma. Moreover, as the tumor grows in between the compact bone and the overlying periosteum, it will lift the periosteum away from the contact bone, and this will produce the situation of a triangular shaped appearance which is known as the Cardmans Triangle. Now, coming to the Ewing sarcoma, we know that the Ewing sarcoma, it doesn't arise from the osteoclast, but it arises from some primitive stem cells located in the bone marrow. And these stem cells are the mesenchymal stem cells and neuroectodermal cells. These primitive cells located in the bone marrow have the capability to differentiate into different types of tissues like nerves, fats, bones, and cartilage. And it is these are the neuroectodermal cells that will give rise to the Ewing sarcoma. The Ewing sarcoma commonly occurs in young age, and it is the result of chromosomal mutations. We have studied in our third year the different types of chromosomal mutations in the form of either deletions, insertions, duplications, translocations, and in Ewing sarcoma, translocation occurs between the chromosomes 22 and chromosome 11. And this genetic translocation occurs between the EWSR1 gene and FLI1 gene. So what happens that when these genetic components are translocated in these chromosomes, they give rise to the formation of EWSR1 and FLI1 fusion gene and fusion protein. This fusion protein is also known as the Ewing sarcoma protein. Now, what will happen that this Ewing sarcoma protein will cause defects in the differentiation of the human mesenchymal stem cells and neuroectodermal cells. And as a result of the defect in the differentiation, the neuroectodermal cells and the primitive mesenchymal cells, they will transform into a tumor known as the Ewing sarcoma, particularly the neuroectodermal cells. And the defect in their differentiation, which is caused by the Ewing sarcoma proteins, which is found as a result of the fusion of the two genes, will result in the formation of the Ewing sarcoma protein. The third malignant tumor known as the chondrosarcoma. As its name indicates, the chondrosarcoma, they arise from the chondrocytes. We know that the chondrocytes are found by the chondroblasts in the cartilage. And therefore we say that the chondrosarcomas are cartilage forming bone tumors. The chondrosarcoma typically occurs in old age, and it commonly affects the proximal humerus, proximal femur, and bones of the pelvis. The radiological appearance of the chondrosarcoma, we will see a mass, that is a lytic lesion located in the medullary cavity. Now, the malignant bone tumors give rise to the signs and symptoms, and the pain in the bone, swelling, and pathological fractures are very common. And most of the time, a patient may initially present with a pathological fracture. So, additionally, the malignant bone tumors commonly cause chronic inflammatory reactions. And we know that the common symptoms associated with the inflammation include the fever, the night sweats, and weight loss. These symptoms are often associated with any chronic inflammatory disease. Additionally, if the bone tumors get metastasized to other organs, they may produce sign symptoms which are related to the anatomical structure and function of that particular target organ. For example, the osteosarcoma, which commonly metastasize to the lungs, will cause signs and symptoms associated with the pulmonary functions. For example, coughing and shortness of breath. To make a diagnosis of the malignant bone tumors, we take a start from the history, signs, symptoms, physical examination, and then we proceed to the X-ray. And certain malignant tumors have very peculiar radiological appearance. Computer tomography scans are needed and magnetic resonance imaging may help in the diagnosis. Moreover, we may test serum for certain tumor markers which are specific for certain malignant bone tumors. For example, prostatic specific antigen, carcinoembryonic antigens, and other tumor markers are examined through blood and serum examination for certain malignant tumors of the bones. And the X-ray findings in malignant tumors and even in benign tumors, they may have a peculiar specific appearance which may help us to make the diagnosis of the tumor. For example, in benign tumors, there is the formation of an outgrowth of the osteochondroma, which is a benign tumor and which results from mutation in the extrastosis 1 and extrastosis 2 genes, and there is the formation of a bony stalk known as the extrastosis. And this bony stalk have here a bony cape which is made of hyaline cartilage. Similarly, in another benign tumor like the giant cell tumor, which arise from the osteoclasts, which are the source cells that are involved in breaking down bone, they may present with multicystic bone lesions. They appear like soap bubbles. Now coming to the osteosarcoma, the radiological appearance is typical of the sunburst appearance where the tumor streaks out like the rays of sun. The Cardmans Triangle, which is formed when the tumor grows and lifts the periosteum from the underlying compact bone, producing a triangular shaped lesion, here is known as the Cardmans Triangle. Now coming to the Ewing sarcoma, here the periosteum looks like a sliced onion bulb, and this type of radiological appearance is very specific for the Ewing sarcoma, known as the onion skin appearance. In Chondrosarcoma, there are lytic bone lesions, and these lytic bone lesions, they give the appearance of a mouth-eaten piece of cloth on the X-ray. Now coming to the treatment of malignant bone tumors, in our last lecture we studied that benign bone tumors, if they produce symptoms, they are surgically resected, and since the benign bone tumors do not recur and they do not metastasize to the remote organs, so after the treatment of the symptoms and signs, for example, pain and other symptoms, the definitive treatment is the excision of the tumor. But when we deal with the malignant tumors, here the situation is different. Because if the tumor has metastasized to a remote organ, then surgical resection of the tumor will not be so much beneficial to the patient. Therefore, confirmation of metastasis is very important by making body scans to know that the bone is located to the primary site or it has got metastasized. And unfortunately, most of the times when patients come with bone tumors, they have got their tumor metastasized to the remote organs. And here the surgical intervention cannot be expected to do more benefit. However, we are left with chemotherapy, radiotherapy, and sometimes when surgery is needed, and it will depend upon the type and spread of the tumor. So at the end, we make a summary that for the bone tumors, no single cause can be identified. And we don't know that what triggers the formation of the bone tumor. However, there are certain risk factors that we can relate. For example, the rapid bone growth, particularly in younger people and children, when there is excessive growth at the bone plates, which may give rise to osteosarcoma. So this rapid growth may provide a fertile field for the development of the malignant bone tumors. Moreover, when there is bone trauma like fracture or injury, it provides a site for bone remodeling, and during bone remodeling, again there is excessive cellular proliferation and bone formation, and it also provides a site for the formation of the malignant tumors. Exposure to radiation play important role in the formation of tumors, and some people have genetic predisposition with a family history of the bone tumors, and this is also a risk if a person have a family history of the bone tumors. Osteosarcoma is the most common primary bone tumor. Then after osteosarcoma is the chondrosarcoma, and chondrosarcoma is followed by the Ewing sarcoma, which arises from the neuroendocrine primitive cells. Especially the osteosarcoma is linked to RB1 and TP53 gene mutations, and these genetic mutations are shared by the osteosarcoma. For example, the RB1 with the familial retinoblastoma, which is a childhood tumor of the eye, and TP53 is shared with the Lee-Fraumeni syndrome, in which there are varieties of tumors throughout the body. The osteosarcoma is made up of large pleomorphic osteoblast cells, and radiologically they present with a sunburst appearance on X-ray, in which the tumor outstreaks like the rays of a sun. The chondrosarcoma has large multinucleated chondrocytes, and radiologically it gives the appearance of mouth-eaten piece of cloth. Ewing sarcoma arise from the neuroendocrine cells, which are small blue round cells, and it will give the appearance its peritoneum will give the appearance of the slight onion bulb. And the Ewing sarcoma is caused by the Ewing sarcoma proteins, which is formed by the fusion of the EWSR1 and FLI1 gene mutations due to translocations between chromosomes 11 and chromosome 22. The treatment of the malignant bone tumors include chemotherapy, radiation, and sometimes surgery.